Hi, thanks for tuning in to episode number 71 of the Doctor Podcast Show, and I'm your host, Dr. Robert Psychard. Today we have a great guest on the show. You will love this program. You'll learn a lot and hear a lot of very important information. And we'd appreciate it if you could subscribe and follow Doctor Podcasts so that we could have additional great guests like we have today. And please like and repost this episode if you like it, and I'm sure you'll love it. Our guest today is Dr. Catherine Nobile. Dr. Nobile is a doctor of clinical psychology. She practices in Babylon, Long Island, here in New York, and she specializes especially in anxiety, phobias, OCD or obsessive compulsive disorder, and also couple therapy. And she treats adults, couples, and families as well. Dr. Nobile, thanks very much for taking time from your busy schedule to join us today to talk about these important topics, these mental health problems or issues or disorders that seem to be increasing in recent years. And maybe you can explain to us why that's the case. The first thing I'd like to discuss, which is sort of a fascinating type of problem, not for the people who have it severely, but just for as an observer, and that is OCD or obsessive compulsive disorder. Can you explain what that is and what percentage of the population has that?
Yeah, absolutely. So thank you for having me. Firstly, I'm excited to be here and excited to talk about all of the different mental health ailments that people are going through and tell you a little bit about them. When it comes to obsessive compulsive disorder, if we really strip this down, what it is a relationship between this intrusive experience, intrusive, uncomfortable thoughts, images, feelings that people may have, paired with this compulsive response that they do to neutralize that fear. And so about 1 in 3% of the population will have a diagnosis or have a diagnosis of OCD within this last year. And about 2.5% of the population will have a diagnosis of OCD within their lifetime. We know that about 1 in 100 adults have a diagnosis of OCD and about 1 in 200 children and teens. So really to understand specifically what's going on with obsessive compulsive processes, it's a bit different than anxiety in that there's a specific relationship between the intrusion and the thing that they're doing, either behaviorally or psychologically, to neutralize their fear.
So it's two parts. There's an obsession, which means you're thinking about something constantly and you can't turn it off. And then the compulsion is you're acting on that impulse in some way. Is that correct?
Yeah, to almost undo the obsession. But I really want to be clear about something. Obsessions are part of the human experience. So all of us actually experience obsessions. No one's immune to that, right? People don't often talk about it, but we all experience obsessions. What happens, though, is we say that folks that have OCD have almost an over-tender conscience, whereas many people, when they'll have this intrusive experience, they might think to themselves like, "Oh, that was an odd thought," or that was peculiar," and kind of go along their day. Someone who has OCD, when they really invest in the intrusion. So they have this uncomfortable thought, and then their brain goes, "Why'd you think that? Does it mean that it's true? Does it mean that it'll happen? Does it mean that you'll do it?" And so they invest in that thought. They add a lot of meaning around that thought, and that's overwhelming and really distressing. And that's when it becomes problematic. The obsession in and of itself is not problematic. It's the investment that they have in it. And then because of that, they feel the need to do something to undo that fear. And so that's when they'll engage in the compulsive process. What we're focusing on is really the response prevention. We want to try to help people respond to their intrusions in a different way. The more that they actually try to stop the intrusions, the more that they feed the intrusions, because we want to, again, set the boundary with their OCD.
Right. Now, I've heard that mild obsession or mild OCD might be good. For example, in school, many of my classmates and myself had kind of mild obsessive disorder, so to speak. But that helped us study and spend endless time working and understanding various complex medical topics. So is a little bit
Mhm.
of OCD good?
This is a really, I think, important question for you to ask because what OCD, how it's often conceptualized, is quite different than what it looks like in the room. And so, having an anxious temperament or even an obsessive temperament is not necessarily a bad thing. Having the emotion of worry is not necessarily a bad thing. That often mobilizes us, right? In its most fundamental form, it's a mobilizer. What happens though
Right.
is when it like becomes exacerbated and it starts to take over rather than it being in the car, it's driving the car. That's when it becomes more problematic. And so oftentimes people think about OCD as being really fastidious or wanting everything in a very organized way or being type A. That's not what OCD is. So what we really want to do is one thing that we want to do is dispel any myths around that. When it's a clinically meaningful OCD, what's going on is it's this intrusive experience that's not mobilizing us to get things done that need to get done. What's happening is it's actually suffocating us
Mm.
and pulling us away from engaging in these value-based behaviors. So if there was an intrusion around your safety, for example, and you need to get to work, get to class, study, do all of these things, but you're having this intrusive thought, like, what if someone will break into my home? If you
Mm.
check your house one time and then go upstairs to study, that's not hugely problematic. But when you're spending 2 hours, 3 hours, spending 10, 15 minutes on each lock, that's not helpful anymore. And again, that's when it becomes clinically meaningful.
Right. So if it interferes with your life and activities and prevents you from accomplishing things that you set out to do, then that becomes a problem. You hear about people who wash their hands like 10 times, and after
Hmm.
they touch the doorknob, they have to go wash their hands again, and takes them half an hour. Is that an example of something that's really severe and needs treatment?
Yeah, I would say that's clinically meaningful. So in its most severe forms, OCD can actually look like a psychotic process. And we can talk a little bit about that. But in terms of contamination OCD, there's two things where it becomes mild to moderate, where it deserves treatment. And that's if it's functionally impairing or if it's taking up a long period of time. So again, to really just clarify, if we have a lot of worry, if we have anxiety that's mobilizing us to engage in value-based behaviors, accomplish tasks, that's not within the realm of what OCD is. OCD really exists when the behaviors are working against us. They're doing the opposite of what we want them to do, ultimately, taking up a long period of time. And contamination OCD is one way that this can manifest.
Right. Now, do people recognize that they have this, and then they seek help from you or other doctors, or does somebody tell them, "Hey, it's not normal to check the lock on the
Mm-hmm.
door 20 times"? How does that work?
Mm-hmm. Yeah, so OCD is characterized as being ego dystonic, which means that the intrusions that they're having are misaligned with what their value is. So they're aware that their fears are unreasonable and
Yeah.
improbable. There's this piece where they feel like they might need to trust their OCD, but something that's really important here is that they understand that the fear is just that, a fear. And it's not that they're playing this probabilities game where they think that it's likely to happen. It's the fact that they can't prove that their fear won't happen. It's not certain that causes a lot of anxiety. That's where it goes back to OCD manifests as an intolerance of uncertainty. And so because they can't prove that their fear may not come true, they engage in a lot of anxiety. Usually it's the person coming in, unless it's a child or a teen, but typically children, it's affecting the family system. But for adults, they're usually the one coming in because they're recognizing that their fear is disproportionate to the situation.
Now, what causes this? Is it genetic, familial, environmental, a
Mhm.
combination of things?
Yeah, like most psychopathology, it's a combination of things. So there's genetic variables. We know that people who have OCD, if someone has, I'm sorry, a first degree relative who has OCD, they're more likely to have OCD. We know that there's something going on in the brain. So oftentimes people with OCD, they benefit from an SSRI, selective serotonin reuptake inhibitor, which tells us something about the concentration and the functionality of serotonin in the obsessive compulsive brain. And then where I live is in the environmental and the personality factors at play. So environmentally, if people live in a really chaotic environment, if they had a home where there was trauma, our minds are so incredibly complex and sophisticated to try to control the chaos. And so PTSD is actually not the only reaction to trauma. What can happen sometimes is when people grow up, again, in chaotic homes or unstable environments, to control the chaos, their brain can develop this obsessive compulsive process. So that's the environmental component.
So you mentioned medication as one treatment. What about cognitive behavioral therapy or other treatments that you offer? Tell us about that.
Yeah. And that's what I do. So cognitive behavioral therapy is the frontline treatment for obsessive compulsive disorder. We work with psychiatrists and recommend an SSRI as conjunctive therapy, but the first line really is exposure and response prevention, which is a type of CBT, cognitive behavioral therapy. And it's really important here because whereas in other ailments, a variety of different therapists can get at different things and help, when it comes to OCD, you really want to be getting cognitive behavioral therapy. And if you engage in another type of treatment, it can accidentally, not intentionally, but accidentally collude with this obsessive compulsive process. And I can explain a little bit more about what we're doing in ERP, exposure and response prevention, but it's definitely the front line, the type of treatment that you want if you have OCD.
So tell us, how do you tell
Yeah.
somebody you really don't have to wash your hands 10 times or check the lock 10 times? Once is sufficient. How do you convince them of that if
Yeah.
their brain wiring is not working well?
Well, that's the beautiful thing. Through behavioral treatments, we're rewiring their brain. So behaviors change beliefs. And in exposure therapy, what we're doing is we're purposefully actually triggering the patient with the thing that they're scared of, intentionally trying to increase their distress. And then instead of engaging in the compulsion, we change their response so they tolerate the trigger. And over time, what we know is the more we look at the trigger, like look at the bully, the more that you run away from that bully, the more the bully is going to come after you, right? In order to set a boundary with the bully, you eventually have to look at that bully. And so OCD in this sense is the bully. So what we're doing is in each exposure, we're looking at that bully, we're getting their anxiety higher and higher and taking away their response until number one, they can habituate physically to the symptoms of anxiety. But number two, and the best part, is they can increase their capacity and their feeling of capability around, I can handle the thing that I'm scared of. So that's what we're doing. Now, how we do that, I often say to people when they come in, the pain of the illness has to be worse than the pain of the treatment, because unfortunately, when it comes to not only OCD, but other mental health conditions, the treatment requires tolerating pain on the patient's part. And so exposure, it's stressful, right? You're putting yourself in a situation that's triggering. And it's saying, I'm going to invest in this treatment because I know it works. The science says it works in service of my long-term self. And therapeutic alliance is really helpful. Psychoeducation is really helpful to empower people so they know. But ultimately, what can happen is this obsessive compulsive process, because it's taking such a long period of time, it's so overwhelming that, again, the pain of the illness is not serving them, that the treatment is, it feels like the next best step. But we have to normalize the fact that it's not fun to do, but it is incredibly effective.
It's great to know. Now, you mentioned time earlier. How long does this treatment take on the average? I guess it depends on how severe your OCD is.
Yeah,
And
go ahead.
you wind up with success where the patient is cured and you don't really have to see them anymore? Or does this require chronic, long-term treatment?
It is treatable. That's the thing is when you're doing any sort of exposure work, you want to make sure that you have, you can explain to people that we know this isn't just theory, we know that it works. So the treatment is relatively short term. The average is about 8 to 20 sessions. I always tell people try to commit between 3 to 6 months of treatment. It's weekly treatment where we're doing exposures in the room, and then each week we have them doing homework because again, we're rewiring the mind. So we want to make sure that that learning has to take place. But 3 to 6 months of weekly treatment with homework yields really great results. And on average, we get about 75% of people have complete remission of symptoms. And we know that at follow-up, they no longer meet criteria. So that is something that's really good for mild to moderate OCD. Now, again, when there's comorbidities, there could be other things going on. That's a factor that's at play here. If something might happen during the course of treatment, we also have to be mindful of that as well, because that's going to inform our care. But it's treatable and it's short term. It really works. It's a beautiful, beautiful treatment. It's wonderful to see people on the other side of it.
That's great to know that you can
Yeah.
treat it, and it's a relatively brief period of time. That's
Yeah.
really good news. Now, let's go on to the next one, which is also very interesting and fascinating, and that is phobias. People who have
Mhm.
fears of certain things. We've all heard of people who are afraid of elevators, things like that. Can you explain what a phobia is? And
Mhm.
is it normal to have some mild phobias, or does that lead
Mhm.
to more severe phobias?
Yeah. So, in terms of like anxiety, there's phobias, there's obsessive compulsive processes. And so really to make the distinction, I think, of what a phobia is, I want to put it in the context. So whereas I said OCD, an obsessive compulsive process, is this specific relationship. You have an intrusive, uncomfortable thought or image, and then you respond to it to neutralize the fear. A phobia is defined by intense and irrational category of fear. So someone with OCD might have a contamination fear, like I won't touch the handlebar, but I can hop on the subway and touch the railing, and that's fine. Someone with a phobia, it's all, it's within the category. So they might, if they have a spider phobia, for example, it's small spiders, it's big spiders, it's photos of spiders, and it's within this category. And it's defined when you said, is it normal? I mean, I always love to ask the question, how do we define normal? I would switch that maybe to
Right.
adaptive, right? Is it adaptive? Is it adaptive to have a phobia? Because a phobia is defined as intense and irrational, it's not adaptive to have a phobia. If you dilute that down to anxiety more generally, yeah, it's definitely adaptive to have anxiety, and we can talk about that. But in terms of a phobia, it's just really how impeding is it? How much does it affect your life? If I'm landlocked and I have a shark phobia, but I'm never leaving where I live, it's not really impeding me to have this shark phobia. If I'm a scuba diver, that's a different story.
Right. Exactly. Yeah, my wife is scared of sharks, but she never
Yeah.
goes in the ocean, but she's
Yeah.
still
Does
very
it matter to
fearful.
her though? Does it diminish any value from her life?
No, not at all. She just
Yeah,
hates sharks.
exactly.
I
That's
say,
what I
don't worry
mean.
about
So
it.
yeah, so it's not impairing, it's not really messing with her life at all. So it's
Right.
okay.
Yeah.
Mm-hmm.
Now we've heard of phobias like being afraid of heights, or being afraid of crowds. But when it gets to the point where you can't leave your home or your apartment because you can't go up an elevator one flight, or if you see two or three people,
Mm-hmm.
you start getting anxious. That's a true phobia. Now, how do you treat that?
Mm-hmm. Yeah. So phobia disorders that responds quite well to cognitive behavioral therapy as well. So what you just mentioned is agoraphobia, someone being homebound or being afraid to leave the home. There's all different types, but what we really want to do is we want to help them increase their tolerance for, again, what their fears are. Now, the big response to a phobia is avoidance. So what that person is doing is they're removing themselves from being around the thing that they're scared of. And as long as they're not interacting with the thing that they're scared of, they're not going to be able to disconfirm their beliefs around it. And so the cognitive part of the CBT is looking at what are their fear thoughts on a more superficial level and on a deeper level, and how do we create some more flexibility around those thoughts. So we do things like cognitive restructuring to help them understand how reasonable is the thought, how realistic is the thought, which again is something that we definitely do not want to be doing in OCD. In phobia, we actually do want to play that probabilities game to restructure the thought and create flexibility. And then from the behavioral perspective, this is where we really get a lot done, is we create gradual exposure, fear and exposure hierarchies where we don't, if someone's scared of an elevator, we're not going to like throw them in an elevator to go 100 flights very quickly, but we create these gradual exposures to help them habituate, again, not only to the physiological sensations of anxiety, but also to their deeper fear. And we do these, again, in session, we do them for homework. We'll do things like imaginal exposures where we'll create scripts and we'll, of whatever they're scared of, and we'll read them over and over again. We'll do things like in vivo exposures, where we'll go out into the world and we'll interact with the environment in a new way, again, to help that relearning happen.
So if you have a patient who's afraid of crowds, let's say, do you have to take them out into a crowd to actually you do that?
Yeah. So we probably wouldn't start there. That would probably be top of their hierarchy. We might start with a story where they're in Times Square and they're overwhelmed and we access all the sensory pieces. I might have them spin around in a chair a few times and then hear the story, an interoceptive exposure. So we work our way up to going to Times Square, but it's indicated to go out into the world. That's the quickest and most efficient way to do it.
And the same thing with elevators, somebody who fears elevators, for example?
Yeah, elevators. I just finished emetophobia, which is a vomit phobia. We didn't actually vomit, but we ate vomit flavored jelly beans. We have to do all the exposures that our patients do. So yeah.
Vomit flavored jelly bean? Where do you get,
We
do you
make
get those?
concoctions. I love your face. It's really interesting stuff. What can I tell you? It's wonderful because in the beginning, it is so it's so overwhelming to people when they come in. These fears, they're like buildings on their chests where they can't live their lives. And by the end of it, there's like some levity to it, and they're laughing, they're looking like this is therapy. It's I'm sorry, buzzed out. It's a totally different experience for them. Hopefully it gets clear.
That looks
Totally different experience for them, which is great.
What are some of the strangest or weirdest phobias that you've encountered?
So again, I would want to reframe that language just because one of the things that often does come along with this anxiety, and also with OCD, is there's a lot of shame that couples with it because people's insides are not always matched to their outsides. And so oftentimes people have a lot of judgment on themselves. And I like to say all of our minds say the wildest things. And so the hardest part, truthfully, in treating whether it's OCD or an anxiety disorder is the shame that's coupled along with it. And so with that, I would, in terms of odd or weird, I want to just reiterate, like we all have odd or weird experiences that we have. But there's quite a range. Again, I treat quite a bit of emetophobia. I've treated agoraphobia, oftentimes, not all the time, but oftentimes is coupled with panic disorder. So we'll treat agoraphobia. Spider phobias, plane phobias, but that's it's the gamut. Phobia treatment, it's very quick. Oftentimes people between 8 and 10 sessions, it's done. So it's a really quick treatment. Yeah.
You also use medications, the same medications that you would use that you mentioned earlier?
So because phobias respond so well to cognitive behavioral therapy, I actually often caution people with medication until they do a round of CBT, especially short-acting medication. Because if you think about this relationship between the anxiety and avoidance, or even with OCD too, I wouldn't want them to be on a short-acting, but with the anxiety and the response, we want to try to prevent them from feeling like they need to depend on something or anything to get over the fear. And so, of course, medication is wonderful and very helpful in stabilizing the symptoms. But when it comes to a phobia, what we want them to do is we want them to, again, for example, habituate to the fear of spiders. And if they take a medication, again, especially short-acting medication, their brain's going to tell them, of course, like the only reason I could deal with this is because I took the medication. So after the 8 to 10 sessions, if they're treatment resistant, then we bring meds in to calm their brains down so they can engage in the work. But usually we like them to do the round of CBT before we bring a medication in. Again, of course, unless there's something else going on as well.
Right. Well, that's great. It's very effective. You mentioned spiders a few times, so I guess you've had patients who have phobias.
I might have a spider phobia. That's why.
What's that?
I said I might have a spider phobia.
Oh, now, do you have spiders in your office that you actually you do?
Yeah.
Wow.
Yeah. I don't have them, but we will go get them. Yeah, it's really interesting. So when I was in graduate school in my doctoral program, that was the exposure that my professor, my mentor, actually had us do as the students. Is she brought a spider into the class, and I was actually the guinea pig because I don't like spiders. I've habituated since I first started, but I was everybody's guinea pig, so because she wanted to show us behaviors change beliefs. So yeah, we'll go to the store and we'll get spiders. And
so should I bring home like a baby shark in a fish tank?
Yeah. If you think that it's impacting her ability to live a value-based life, I say go for it.
So the next condition I'd like to discuss is anxiety. I'm seeing more and more anxiety in my patients in recent years, especially after COVID. Yeah, a lot of my patients tell me this. I'm an ophthalmologist, so they don't really have to tell me, but they do anyway. They tell me they're more anxious, they're nervous about everything. Of course, the world is crazy these days, so everybody's a little nervous and anxious. But I'm seeing more and more patients on medications for anxiety, and I'm also seeing much younger patients. In the old days, I used to see people in their 40s, 50s, 60s, but now I'm seeing teenagers, people in their 20s and 30s who have significant anxiety disorders, and they're on medications. So what's your experience with this? Do you think it's increasing? Why is that? And tell us what causes anxiety.
Yeah, there are a few factors at play. Like you said, I think for this population, the millennials and Gen Z specifically, I'll maybe first start. There's been a normalization of communicating your emotional experience. So I think that people are reporting their anxiety in ways that they weren't previously reporting it. I think that's a part of it. Also, since COVID hit and there was a global pandemic, fundamentally anxiety is an adaptive emotion. It's our threat response. And it functionally made sense for us to all feel more anxious, right? The anxiety fit the facts. So not only that, but then the consequences of that systemically triggered a lot of anxiety. And the formula for anxiety is an overestimation of the threat and an underestimation of our ability to cope with that threat. And so
that's a great definition. I like that.
Yeah. Yeah. So what's happened over time, though, is that when it's rooted in a global pandemic where the threat was very real, and then there were all of these different things that we were told to mitigate the risk and stay safe. And then this is all, again, the systemic conflict and all of that. There was this overwhelming sense of this is a huge problem and I'm not equipped to handle it. And we can't turn our brains off like a light switch, right? That imprint is in our mind. And so moving forward, there's been more cautiousness, more wariness. With COVID, though, the real uptick that we saw, even more than anxiety, was in OCD, and that was a little bit more complicated. But with because a lot of the things that were previously like maladaptive compulsions, we were being encouraged to do, especially in the beginning, like wipe our groceries with Clorox and things like that.
Right, I remember
that. And I would treat OCD where that existed prior to the pandemic, and that was like, we're not doing it. And then once the pandemic happened, we had to really shift what's a reasonable response to this. So that's a different story. With anxiety, though, I think that it's twofold. I think that in part, people feel more comfortable being open and honest about their experiences. And then in part, there was this global experience that we had that, fit the facts, that it was an anxiety provoking situation and people can't turn their minds off.
Right. I guess that explains why younger people have it more as well, because they were exposed to the same facts.
Yeah, but then it compounds on top of that too, because if you think about what their communities looked like, a lot of these people were in school and in like developmentally incredibly important times for their identity and in terms of socialization. They weren't. So things like social anxiety spiked up, which is a fear of negative evaluation. So it was not just the pandemic, but all of the systemic factors associated with that.
Right. Now, is this also a genetic and familial trait, increased risk
Yeah.
if you have other family members with it?
Yes, definitely. So they go hand in hand here. So there's definitely an organic component to anxiety, and there's a genetic component to anxiety. When we have family members who have anxiety, we are more likely to have anxiety. But
Mhm.
there's something else at play here where if you have a caretaker who has anxiety, you're also going to grow up in an environment. It's like those helicopter parents where they may prevent their kids from experiencing failure or fear or adversity, which prevents them from learning it's okay to experience failure or fear or adversity, right? And so
Yeah.
those are really important lessons for kids when they're young to feel negative feelings and then learn how to cope with it effectively. And so when you grow up in an environment with an anxious parent, you're more likely to not have opportunities to do that. And that's going to also increase anxiety. And also you might learn messages from your environment, not only parents, but school friends, your community. The world's not a safe place, which then again, I'm sorry, can foster more anxiety for people.
Right. And what is the treatment for anxiety?
So anxiety responds really well to second and third wave behavioral therapies. So a second wave behavioral therapy, for example, is cognitive behavioral therapy. An example of a third wave behavioral therapy is something like acceptance and commitment therapy. And what CBT does is it's focusing on really anxiety manifests as worry about worry. It's worry about a lot of different things. So going back to the way that we're defining things, where OCD is this specific, intrusive, compulsive response. Phobia is categorical. Anxiety is this generalized whack-a-mole of all the website tabs open in your mind, right? And so worry becomes protective. Going back to kind of what you were talking about when you were in med school and that worry, it helped you succeed and thrive, right?
Right.
So worry helps us in a lot of ways. Me too. If we can predict all of the things that might go wrong, then we can prevent it until we have so many different worries that we become overwhelmed and under-resourced. And so what we're doing in behavioral therapy, cognitive behavioral therapy, third wave behavioral therapies, is we're trying to shift a person's relationship with their worry. And so from a cognitive perspective, we want to understand what's the function of the worry. Is it helping us? Is it harming us? From a behavioral perspective, we want to increase tolerance around whatever the feared consequence is. And then when third wave behavioral therapies came along, they were so wonderful and resourced us because what happens when our worries are reasonable and we still can't do anything about it, right? So that's
Right.
an example of
Yeah.
third wave behavioral therapies like mindfulness. And so what we do in therapy too is we help people look at their experience rather than from their experience. So understanding like I might have this worry, and I'll just say an example. I could have a worry right now. I can't prove that I might have some health ailment. I don't think that I do, but it's possible. And so I might worry and worry and worry about it. It's not going to change the outcome in any sort of meaningful way. I can go to the doctor, but any sort of really significant or meaningful way if I worry and worry and worry about it all day long. And so it's understanding, does the worry serve me? And when it stops serving me, how do I remove myself and stop engaging with it? And so it's increasing that mindfulness muscle to help people disengage from the worry when it no longer helps them, if that makes sense.
Yeah, so the third wave is a sort of a mindfulness
Third wave is, acceptance and
strategy.
commitment therapy, dialectical behavior therapy. It's rooted in mindfulness and more Eastern principles.
Right. And do you use medications also in more severe cases of anxiety?
Yeah, so we know mild to moderate anxiety responds really well to evidence-based psychotherapy treatment. When people have, especially when they have physical symptoms of anxiety, if they're noticing a lot of irritability, feeling keyed up, we will recommend an SSRI and work with psychiatrists. When people are so preoccupied by their cognitive symptoms that they're not able to engage in the room, right? The medicine that we use are our words. So if they're so preoccupied that they can't engage with that, we'll use medication again so they can calm their brains down so they can engage in the work. So an SSRI actually can be incredibly helpful for anxiety. Again, when it comes to anxiety, psychiatrists will caution against this, against using a short-acting medication because it can, for a multitude of reasons, but as it relates to the process, it can actually collude with this idea that they can't tolerate their emotional experience, which then prevents them from being able to tolerate their emotional experience.
Very complicated there.
Yeah.
How long does this treatment take, or is it extremely variable for treating anxiety?
More generalized anxiety?
Yeah.
Yeah.
I-
So
Is it
I
a
would
long
say,
process, or like you mentioned, phobias are pretty quick,
yeah,
a
it's like
few
it's 10
months?
sessions. Yeah. So with more of a generalized anxiety disorder, about 3 to 6 months of treatment, we know that people do make significant gains. An anxious temperament is something that, again, if you think about your mind as a car, when people come into therapy, anxiety is driving the car. 3 to 6 months, it's in the back seat, but it's always going to be in the car, right? And so
That's
we
a
have to
great
accept.
analogy. Love that too.
Yeah. Um, I have a lot of people that come in and they're just like, I don't want to be anxious anymore. That is so detrimental that not only can that not happen, it's so detrimental. We need anxiety. So it's really about changing their relationship with their anxiety. And so in terms of the treatment, we want to really also define what are their goals. It has to be to get the anxiety in the back seat. If it's to get the anxiety out of the car, you're not going to get up in the morning, right? We all need it to some extent.
Right, to function in a crazy world. Does
Exactly.
social media aggravate or exacerbate all these things that we're talking about? The
Mhm.
phobias, the OCD, the anxiety?
Yeah, it's such a really, really great question because we live in this world where there's so much information coming at us. And it's really twofold because on the one hand, what it's done is it's normalized people's pain and it's given them a sense of community. And in that way, it's been helpful. And the way that kids connect today is quite different than how people used to connect. And so to find an environment where you can find a community gives a sense of belongingness, which can be really great. And so in that way, social media is helpful. In so many ways, it's unhelpful. Not only are they being inundated with information that's not rooted in evidence and not helpful, but there's confirmation bias at play. And so if they have worry or anxiety, they can find somewhere on the internet to confirm that. Above that, there's a lot of social comparison. So oftentimes people with anything, anxiety, phobias, whatever we're going through, we can find someone on social media who's doing it better, telling us what to do, who isn't struggling. And in that way, it really exacerbates and inflames all of this. So I really caution people to be protective over the media that they're digesting.
So do you tell them to go off social media completely, or how do you deal with that?
Hmm. It's a case by case basis because we have to figure out what's the function of it. And when it comes to decision making, the way that I really distill this down is it value based or is it fear based? And so if going on social media or going on a date or hanging out with a friend, pick your decision. If it's value based and we can identify which value this is serving, I'll support you, right? It's your life that you're living, not mine. If
Right.
it's fear based, then we're colluding with this process. So then I would say, what would it be like to not do this, right? Is it setting a boundary or are we avoiding? Because those aren't the same thing.
It's a great way to analyze it and figure it out. That's
Yeah.
great. Next thing is couple therapy. There seems to be an increased incidence of divorce in the USA. I've heard it's up to about 50% or something like that.
Mm-hmm.
Is that true? And why is that?
Yeah. Yeah. So couples work is it's this other passion of mine that I love. I find it so interesting. And it moves, oftentimes there's anxiety in a dyad between two people. But it's kind of a different thing that we're working with. And so um the rate of divorce this year, it was 41% this past year. So it's between 40 and 50%. But um, it's interesting. There is this common conception that there is the rate of divorce is rising and rising and rising. We've noticed that it's actually starting to go down, but there was a slight uptick in 2021, 2022. But there's a lot of different things, just again, in terms of like the zeitgeist and culturally what's going on, people are getting married much later. People's beliefs around marriage have shifted. People's sense of independence and individuality, their needs have changed. So all of those things have ultimately impacted marriage. But outside of that, just in terms of couples, the way that relationships are structured is changing as well.
Right. So do you think that it's a good idea before you get married, maybe while you're engaged or even before that, they should meet with you or another therapist and,
I
find
do.
out if they can live together and for a
Hmm.
long time. Maybe
Yeah.
you might find some red flags that can't be fixed and say, hey, you guys should move on.
Hmm. I definitely recommend all people, married, not married, wanting to get married. It is, for some people, they enter into couples therapy because they are about to break up and they don't know what to do. For some people, they think they're in a good relationship and they want to make it better. When we're in a relationship, there's two people. You have two lives, two sets of history, two ways of responding to things. And so I like to think about in even the healthiest form, for some, therapeutic treatment is a necessity. And for some, it can be an oil change for a car, right? In our relationships, all cars need an oil change. I know all relationships need an oil change. So
You've
couples
got a
therapy can
car
be
and
that too. I
You've
love
got a
car
car
analogies.
analogies. I use car analogies as well as an
It works,
ophthalmologist.
right?
It works because everybody knows about cars and stuff,
Yeah.
and they go,
Yeah,
"Oh
I
yeah,
didn't
well,
realize. There's something about cars this evening. I have a lot of metaphors, but yeah, there's something
your
about the
car
car
now,
metaphors you're pulling out in me.
your car analogies are awesome. I
Yeah.
love."
But yes, I definitely recommend that before, if people want to get married, a lot of it's many patients I've noticed even in my own practice are coming to me either right before they get engaged or right after they get engaged and I see them through getting married. And it's really helpful, again, just because you're two separate people. You have different experiences of love, of emotions, of connection, of values. And so it's helpful not only on a communication level to iron things out so you can communicate effectively, but also to understand the pain points in your partner so you can approach your partner with kindness and compassion. And just give yourself a toolbox because, of course, life can get hard and you want to feel like you have a partner in it.
Right, things happen all the time. Now, how do you explain people who are married 20, 30 or more years and then decide to get divorced after that? I don't know if you
Mhm.
saw this in the news. I happened to turn on the internet a few hours ago, and apparently Kelly Ripa, who has that morning show
No
on
way.
ABC, her husband
Um,
is her guest host. And she
yeah.
apparently said to him, I'm thinking of getting a gray divorce, which I'd never
Oh,
heard that term, but apparently it's for people who have gray hair. And apparently
oh.
he like freaked out because she said this
She said
live.
it on the show?
That's what I read. I didn't watch the show.
Oh,
I'm
maybe
seeing
that was a
patients.
bit, but if it's a bit, it was a cruel joke.
It's a good publicity stunt. I'm
Yeah.
sure they're going to get more
These things
people
do
watching
happen though.
tomorrow. But How do you explain that? So people have been
Yeah.
together for a few decades and then they decide they've had it.
Yeah, it is. It's not uncommon. There's a piece where any sort of transitional period in our lives are ultimately going to impact our relationships. And oftentimes when people get married, their they can fall into a more transactional pattern where they have, oftentimes they'll have kids, they'll have their mortgage, their financial responsibility, their jobs, their personal ventures, and they get into the rhythm of life that they go on autopilot. And again, the dynamic between them becomes more transactional. We wear a lot of hats with our partners. We're romantic partners, we're meant to be friends, but we're also like employees, right? We're colleagues in a lot of ways too. Because we have to manage life together, and we're co-parents together oftentimes. And so certain hats are being prioritized over other hats. And when certain transitional periods happen, like retirement or your kids leaving the home, oftentimes people can look at each other and they don't know how to get back to feeling close and connected. Their dynamic has shifted. And so a lot of things that maybe have been avoided or brushed under the rug, a lot of language that maybe they could have used but never learned the skills to use, they now need now. So it's not uncommon at all for people after they're quote unquote empty nesters or moving into act 3 of their lives that they'll notice more marital conflict and come into the office then.
Now, you mentioned children. Do you also treat children of people who are having difficulties or thinking of divorcing?
Yeah, so when it comes to small, or not even small kids, but when it comes to kids, there's 2 ways that we can go about it. So I specialize in a therapy called emotion focused therapy for couples. It's a gold standard treatment, evidence-based treatment for couples. Gottman and EFT are the 2 gold standard. For family therapy, there's emotion focused family therapy, which also has some good data behind it, and we're continuing to research it. Emotion focused family therapy is a systemic therapy, though, where you're looking at the entire family system to figure out how to increase accessibility, closeness, connection, all to better support the child. That is a systemic attachment-based lens to address some of the problems that you're talking about. There's also parent management training, which is a behavioral treatment that we'll often utilize for kids who are struggling. They might have anxiety or different behavioral issues that could be coming from the parents getting divorced or coming from familial conflict, but that's shifting the ways that parents are responding to the child to help the child. So that's a little bit different. The identified patient in that situation is the kid. So that's a different thing than couples and family therapy.
It's very complicated if there are children involved as well. Now, does
Mm-hmm.
the couple therapy, is that require, again, chronic long-term treatment and sessions, or can you treat a dysfunctional couple for 6 months or 12 months, help them get through their issues and problems, and then they live happily ever after, hopefully?
Mm-hmm. Yeah. Uh, Couples therapy does not have to be a chronic, long-lasting treatment. So the average length of time for couples therapy is 6 months. And EFT, emotion focused therapy, which is the treatment that I specialize in, there's been a wealth of research on it, and 90% of couples are quote unquote in remission. They're communicating marital or relational satisfaction at the end of the therapy. And 75% at follow up, usually 6 months and a year, they don't meet criteria for needing relational therapy at that time. So they're able to take the tools that they've learned in treatment and extend it over time. And it's because, again, it's an attachment-based, EFT is an attachment-based therapy where we're really teaching people how to feel safer and more secure with each other, so that when conflict does arise in the future, there's always going to be conflict, but when it does arise in the future, their stuff isn't bubbling up in the same way. There are certain factors, though, at play here when a couple comes from trauma, when one or both members of the couple have childhood trauma or past trauma, diagnoses of PTSD, it becomes more complicated because, especially childhood trauma, we know that the way that we were loved as children does impact the way we do love and receive love as adults. And so when people come to couples therapy when they've had quite dysfunctional childhoods. They're trying to do something that they never learned, and it becomes way more difficult. They're way more defended. And so it's not years and years and years, but it does take more time because their protective mechanisms, for very good reason, are much, much thicker and stronger.
Right. So if one of the couple has some other problems, for example, anxiety, that makes it even more complicated for you.
Yeah, mostly when if it stems into their childhood, because what we know when we're working from the lens that I work through is that attachment exists from the cradle to the grave. So if right, like attachment is always going to exist. We are social beings, and so whereas a parent-child interaction, right, it's always about the kid. Adult attachment is reciprocal, but it still exists. And so if there is a dysfunctional attachment that someone had, we're not prisoners to our childhood, but it is data that we need to take a look at, because if we lived in an environment where we didn't learn about our internal experiences, when we didn't know what safety and security felt like in relationships, we have this part of our bodies that longs for that. But if that was shut down in our lives, which really manifests more as trauma, anxiety too, but that's more like trauma, it's going to be very difficult. Not impossible. I work mostly with traumatized couples, honestly, but it's more difficult. They're more treatment resistant.
So you need to figure out how to get both of the people, the couple, to drive the car simultaneously. They both have their hands
Two
on the
wheels.
steering wheel and driving
Yeah.
together.
Yeah.
That's very interesting. Now, how do people know when to contact you or another therapist? What are the signals or red flags that it's time for me to seek help and treatment, that I can't handle this?
Yeah, so there's some concrete markers and then some reflective questions that I would have them ask. First, I would say, in terms of their day-to-day life, what are their mood levels? What are their energy levels? Basic self-care are they engaging in? And have they ruled out any sort of physical ailment that could be contributing to it? Because we all deserve to have good energy, good mood, and there are treatments, whether it's for a lot of things, not all things, but for a lot of things, whether it's the etiology is physically or psychologically, or many times it's both. We have supports out there and resources out there to help us get from point A to point B. So I would want everyone to just check in with themselves, like how do I feel every day, and do I feel grounded? And if they're noticing, oftentimes psychological symptoms do manifest physiologically, that their sleep is off, that their eating is off, that they're feeling like their heart's racing all of the time. If they're noticing functional impairment, they're getting feedback from the people around them, that like if they have a point where like they just aren't feeling like themselves. So oftentimes, physically we can feel disjointed, we can feel numb. And I ask people, go upstairs and say, like, what's the story that you're telling yourself? And if it doesn't feel aligned with how you want to live your life, that's a really good marker that it's not going to hurt you to reach out to a therapist. And so just resource yourself with information, because one thing about invisible illnesses is that it can be very lonely. And like I said earlier, it's coupled with shame. And if just some psychoeducation can be really empowering for people. And so that's the first piece. And then the second piece, in terms of self-reflective questions, is just checking in with ourselves and asking ourselves, what does a value-based life look like? I know I've said that word a few times because that's the big question. I'll often ask people, if you're 105 years old and you're sitting on a rocking chair on your porch and you're looking out into the world, what do you want to reflect on? What made your life good? And are the things that you're doing today moving you towards that moment? And if they're not, can you do something to fix it? If you don't know, we might have an idea. So that's the other piece that I think is always a good question for all of ourselves to ask. We all get into autopilot. And that can be a really good marker too. So therapy can be useful for a wide array of things. Like I said, for some, they're homebound, they're entrapped by their mind, and it's difficult for them to get out of bed in the morning and to function. And we can really help in that way. And for others, the pain that they're experiencing is really invisible. They might on the outside seem quote unquote totally fine, totally put together, high functioning, but on the inside they feel really lonely and really ashamed. And so there's support out there for all people. It's just you have to find the right therapist, because no matter what the specialty is, you have to feel comfortable.
Right. So I was just going to get to that. You read my mind. So everybody in Long Island should come to see you, because this has
Oh,
been
thank you.
incredibly informative, educational, and I can tell that you can develop a great relationship with the patient. But what do people in other parts of the country do? How do you know that a psychologist is good, like you are, obviously? Is there any
No, that's
way for
kind. Thank you.
people, yeah, is there any way for people to research that and figure it out?
Yeah. It's especially hard. The mental health system is really, really difficult to navigate. If you had a dental problem, you wouldn't go to a cardiologist. But when people it's different for mental health though. Oftentimes, if people have OCD, it's therapy. They don't know what types of therapy
Right.
are out there, and it's really problematic. And on top, there's a bunch of systemic issues. But luckily, going back to social media, not totally social media, but in terms of the internet, like we are resourced with information. And so the resources like Good Therapy, Psychology Today, people can go on, put their zip codes in, and find specialists. Psychology Today is kind of like the ZocDoc for therapists, and can really help people navigate in terms of where they live, what types of therapy to find. There's also, since COVID happened, they've expanded laws where New York isn't one of them yet, unfortunately, but many other states, there's something called Psych Pact, which allows people to practice across state lines. And so there's certain states that participate where you can see a therapist in Connecticut, for example, if you live in Tennessee. And so if you're amenable to teletherapy, your resources have really widely expanded. And I think it's really wonderful as well. So
Do you
that's
do
another.
teletherapy or televideo therapy
I
also?
do. Yeah. So we started in COVID.
So
I'm
you're
about
working
70.
24/7.
Yeah, so but New York isn't a psych pact state, so
Oh, I see.
unfortunately,
Just New
yeah,
York.
not yet. But my hope is that eventually it can. But during COVID, many states expanded and gave temporary permissions for us to practice across state lines because
Right.
people were fleeing New York and all of that.
Yeah, it is.
But I do virtual, like, so oftentimes I'm on Long Island. A lot of my, I practice throughout New York, though. Many of my patients live in Manhattan or Westchester. I worked in the city for a long time, so that's where a lot of my resources are as well. So I still do therapy for people who are not on Long Island. A lot of it's in person, and we get good results either way. And so I think oftentimes people get worried about telehealth, but it's worth doing. The thing that I would say is find someone you're comfortable with. And I would pick the person you're comfortable with, working with them virtually, over finding someone you're less comfortable with just to see them in person. Because
Hmm.
goodness of fit really matters. Like I said, our medicine is our word. So you have to feel comfortable.
That's a great tip. That's awesome.
Yeah. Yeah.
So this, as I mentioned earlier, has been very informative, educational for me, and I'm sure the audience will love it as well. I learned a lot of things in the past hour, and I want to thank you again for taking the time to do this. It's helpful for many people out there.
Yeah. Thank you. I appreciate what you're doing. I think it's helpful. Let's get, evidence out there. So I appreciate you having me, and wish you all the best.
Thank you very much.